friends, and welcome to this episode of Bringing the Future Forward, Innovating for Impact, Transforming the Delivery of Treatment, Recovery, and Behavioral Healthcare Solutions. I'm your host, Bobby Patrick, the Vice President of Strategic Growth and Policy for the Medical Alley Association, and today's conversation is an important one, and we are fortunate to be joined by several leaders who will share their expertise and insight on many of the most pressing issues impacting the delivery of behavioral healthcare. We have a fantastic panel later in the program hosted by Medical Alley Association's own Frank Jaskulke that will have an in-depth conversation on how technology impacts access and outcomes in treatment, recovery, and behavioral health. Before we begin the conversation though, I'd like to thank our sponsors of this Bringing the Future Forward webinar series and have them say a few words about who they are. Let's start with Keith Schoolcraft, Chief Guru CEO from A Couple of Gurus. Keith?
Hi, my name is Keith Schoolcraft. I'm the chief guru of A Couple of Gurus. We provide managed services for our customers as well as managed security. And I always like to leave the community with some food for thought. So I love the idea of bringing the future forward. I was recently on an airplane back from New Jersey, and I was reading a book. And in the book was telling the story of Disney and how Disney, when he had the concept for Disneyland, he had to try 300 times to get financing for Disneyland. So we would not have Disneyland today if it wasn't for Disney's tenacity. And so that made me think that success has nothing to do with what we think it is. It has everything to do with how we face failure. So just food for thought. Thank you. Proud to be a sponsor of this community.
Great. Thank you, Keith. Next up is Kevin Hogan, CEO of Diversified Plastics. Kevin?
Good morning, Bobby. Thank you. And good morning to everybody here. And DPI is very involved in the Medical Alley community with participating in a number of different events. The key thing that we're communicating in this and other webinars is our involvement with the Medical Alley Starts program. And DPI is a legacy injection molding company. We're actually 100% employee owned, so 100% ESOP company. And our focus is to help startup companies in the medical community, either through our legacy molding or our additive manufacturing technology, which is powered by Carbon's DLS engine. And that basically allows companies to get to market much faster with their product prototypes, get to clinicals faster, and be able to cut the time to market considerably. So we like to communicate our involvement not only with Medical Alley overall, but specifically in the emerging and the startup area. And we're just very happy to support these broad programs that Medical Alley brings. So thanks, Bobby.
Great. Thank you, Kevin. And thanks to both, again, to the Couple of Gurus and Diversified Plastics for their support of this webinar series and the Medical Alley Association. Now to our first guest. Today, I'm fortunate to be joined by Dr. Joseph Lee, the president and CEO of the Hazelden Betty Ford Foundation. Dr. Lee is the 8th president and CEO of the Hazelden Betty Ford Foundation and the first physician to serve in that role. He previously served as medical director for Hazelden Betty Ford's youth services, where he established himself as a thought leader on all matters related to addiction, mental health, and recovery. His experience from across the country provide him with an unparalleled perspective on emerging drug trends, co-occurring mental health conditions, and the ever-changing culture of addiction. We're fortunate to have him with us today to talk about how Hazelden Betty Ford is continuing to lead the way in providing hope for and improving the lives of patients and their families around the country, and how the events of the last year plus have impacted its work. Dr. Lee, welcome, and thank you for joining us today.
Thanks for having me, Bobby. It's awesome to be here.
Excellent. So, you became the president and CEO of Hazelden Betty Ford Foundation in June, and just a couple months ago. So let's start here with a sort of an easy one. Tell us a bit more about your background and what your journey was to where you are today.
Yeah, I'm an immigrant, and a lot of these stories actually, I've been working for Hazelden Betty Ford for 13 years. I didn't tell, but I think it's important to share now because of the context we're in, both of the pandemic and a lot of civil turnover and discussion going on. So I'm an immigrant and a naturalized citizen. from Seoul, South Korea originally, but I grew up in Oklahoma, so I'm an Oklahoma Sooners fan. And I did all my schooling there and med school there, and then I did my residency training at Duke University in North Carolina. And then I really cut my teeth at Johns Hopkins in inner city Baltimore, and I learned a lot of lessons there. And so, I'm the first physician CEO, and I'm the first non-white CEO of an organization, and that symbolism doesn't escape me at all. When I was at Johns Hopkins, there's a story that I tell that really inspired me to do better. And Johns Hopkins is a wonderful institution, but in the mornings in inner city Baltimore, I would work in these schools with social workers, aunties, grandmothers, patching together care and support for kids there who were really marginalized and didn't have a lot of resources. And then the afternoon, just a few blocks away, I'd walk to the ivory tower that was Johns Hopkins, and I'd see people in this VIP clinic, consultants who'd fly in from across the country to have their kids treated. And everyone was treated well, but the discrepancy in care really struck me. And I really made a vow to myself at that time that I was going to treat every family and every kid I saw as a VIP in my heart. And that's something that really aligns with the mission, the proud mission of Hazel and Betty Ford. So it's a tremendous honor. And there's a lot of responsibility that comes with being a physician CEO with quality and ethics. And so everything from DEI to what we innovate into the future, I take very seriously.
Very interesting. And so, sort of building on that about treating all families as VIPs, before you became CEO, you were working directly with patients as the leader of Hazel and Betty Ford's Youth Continuum. And since you're only a short few months removed from that hands-on work, can you tell us a bit more about the trends that you saw or are seeing, particularly in the youth population?
Yeah, some of the things that we predicted would happen, unfortunately, happened. And you're seeing it now, and you see it in the newspapers. We predicted that more people would slip through the cracks, and that a lot of young people and families wouldn't get help. We predicted that many young people would have a crisis, mental health wise, and with substances. The mental health part is getting more attention now, but we predicted this would happen, and unfortunately, it's happening. And historically, in downturns like a pandemic, substance use goes up, mental health rates climb. So we knew there were going to be more people in need. And at the same time, we recognized that access to care was going to be difficult. And so there's a story I want to share about an organization that I'm actually really proud of, because it speaks to how we vote with our feet, and it speaks to the dedication to our mission that our staff have. When the pandemic started, we're in a stigmatized industry resource-wise. And so it was very hard for us to get masks. We were paying $6 per surgical mask. We were having it shipped, and it was being blocked at customs from China. I mean, it was ridiculous, our efforts to try to get testing and masks and PPE for our staff. And it was a very scary time. And I was right there on the front line with them. But we knew we had to keep our doors open. We knew we had to do virtual care and a lot of innovative things to help more people. And I want to say, and I'm very proud to say, that a year and a half later, we are now nearly 90% of our staff are vaccinated. And we made it a requirement to have vaccinations starting in May. It's a plan that we were pretty quiet about. We did it very positively. We actually use treatment principles to get people, because we're a behavioral change organization. So we use motivational interviewing, we use contingency management, and gave prizes out. We made it positive. And now we're about the safest healthcare facility anyone can enter across the country. And so going from the back of the line, a real underdog story, to where we are now, knowing what we needed to do, knowing that we had an uphill climb in trying to help people through this pandemic, is a really inspirational story. And I share that because our housekeeping staff, our front end staff, our drivers, our nurses, our psychologists, our doctors, our counselors, I'm so proud of their efforts and how they're all lock in step, because we're a healthcare organization. That means we protect the most vulnerable. We know that people of color and people with substance use disorders are more likely to contract COVID and more likely to have bad outcomes. And so it was really solid what a North Star was. And we got there. And so it's just something I wanted to share, that through this pandemic, it wasn't all doom and gloom. We did a lot of innovative things, and we're showing the evidence that we're primed and poised to help people despite the pandemic.
It's, and we're going to talk a little bit more about stigma later in our talk here, but it's incredible that that had an impact even on the cost of getting something as simple as a surgical mask, and everyone those were in demand across the board, but that's pretty incredible. And so, as you noted, during the pandemic, what you thought would happen, especially with youth, was right that the addictions increase. And unlike other diseases, as addiction relies on an intimate social network to recognize it and propel the addict to get help. And the pandemic, again, as you noted, disrupted those intimate social networks. We can't see our friends and family, our coworkers, our teachers, et cetera. And so how has Hazelden Betty Ford adjusted to help and continue to lead the fight against the silent epidemic of despair, suffering, loneliness, depression, and overdosing that has occurred throughout the COVID-19 pandemic?
Yeah, that's an excellent question, Bobby. And I know many of your other guests are going to talk about innovation because this is where innovation comes to play. One of the headlines that's well publicized, and there's another one that's not. The one that's well publicized, a lot of people are dying. Overdose rates are going up. The pandemic, a lot of people are suffering alone. One thing that's not talked about a lot is that our disease that we try to help with, addiction and related mental health issues, the way people access care there is a little bit different. People really with addiction or substance use disorders, as we say, they need a bit of a nudge. They need the intimate social network of the loved ones, the friends, the communities around them to have that gestalt check to get help. And they need that love, that how are you doing? Let's go grab a cup of coffee. I'm worried about you. And as you can imagine, when those networks are frayed, when those networks are strained on their own, when they're dealing with their own problems, you're going to have people fall through the cracks. And that's what we've seen, is that our people need a community. And a good thing about innovation is this, simply put in a scientific term, our organization throughout our history, we're all about this term called recovery capital. That's really been the magic of our organization. Recovery capital, simply put, is it's those variables within a person or the variables outside the person in their environment that really help their recovery journey. And the magic of Hazelden Betty Ford has been starting communities of recovery. It's not just a treatment, involving family members, building networks of people, making it okay to talk about addiction and bringing it center stage for the American public. And so we decided, how are we going to capitalize on that? So we did a number of things. We were already developing a virtual platform for geographically disadvantaged patients. We rolled it out early, and so our Recovery Go platform happened, and we moved tens of thousands of patients instantaneously over into a virtual platform. And we have more plans in the future. We started to double down on our digital products. We started to double down on our consulting, our prevention programs in schools that people don't even know we have. We have a very robust prevention line, by the way. And so we started to think about, how can we affect recovery capital and help people in non-traditional ways because of the pandemic? And so we kept our brick and mortar open, of course, but we knew that people needed more care than ever before. And we're going to do even more stuff into the future. We're going to expand into mental health. We have really great strategies to broaden our ramp, really meet people where they're at, improve our family care, share our know-how with the rest of the industry in the world. And so the pandemic has really galvanized innovation within our organization, and we're feeling very purposeful.
Great. And so you mentioned rolling out your virtual care platform, and so that ties in together with keeping not only your comments earlier about keeping your staff and safe, but also your patients. And can you talk a little bit more about that virtual care platform and rolling it out, and how was it received by patients? How did the uptake go up over time? Can you just talk a little bit more about that experience?
Yeah, actually, the seasons change with virtual care. So when we rolled it out, a lot of patients were grateful. So I'll just give you a little anecdote, because I was actually using the virtual care platform to see patients. So I know exactly how it worked. And it worked really well. We had the capacity in our virtual platform. Now everyone has it, but at that time, we had the unique capacity to run group therapy as well as individual. And we could do psychiatric visits, medical visits. We could run all kinds of visits through the platform. There was a communication relay built in, consents and release of information signed. So it worked out pretty well for us at first. And I had patients who were anxious tell me, I feel really empowered doing virtual care because I can roll out of bed with a bowl of cereal and talk to you virtually. Because, for a lot of patients, one of the barriers is the difficulty and perhaps the intimidation of finding a therapist office or driving someplace. And so giving them more options was great. But I want to say that the narrative has since changed a little bit. People are now clamoring for in-person again. They can't wait for us to have better safety protocols because they want in-person as well. And I think what you're going to see in the future is a diversification of how we reach people. People are going to reach people or get connected in hybridized ways, in lots of different manners, and we're prepared for that.
So is that something that you will work with the patient on ahead of time, where there will be certain visits scheduled for in person and some for virtual, or will it sort of be as the patient is sort of adapting, meeting them where they are? How will that work?
Well, we actually had a plan for this hybridized thing where people could choose. You want to have the patient choose what is preferential for them. And so some people, for example, who are geographically far away may just want to continue to do virtual care. Other people really want that in-person touch. They're very tired of web platforms. They want that human connection. And we've all heard this, right, in business meetings and whatnot. And so there's a longing on all sides. Some people want apps. Some people want portals. Some people want their families engaged in different ways. So the only hiccup in this has been the Delta variant, because we were actually piloting ways to do in-person outpatient in a safe way. We still have those pilots going with vaccination status and all these protocols and testing. But the Delta has made it harder for us to do in-person outpatient en masse right away, but we're going to get there. And I think our future state is going to be a hybridized version where people can choose their path in how they want to interface with their recovery.
Very interesting. And I grew up in a small town in southern Minnesota, and I know that having the virtual care options certainly would be impactful for people that I grew up with, not just from, not having to drive, but also, and again, coming back to the stigma piece, not having to, park near the therapist office or whatever. So really powerful stuff there. And so talking about that moving forward and your plan to roll it out, do you think it will stick? I mean, is this something that even as we get further on 3-4 years from now, do you think that the virtual piece will continue to stick across the board, or will it be something that is more just for rural-ish or far out areas?
I think it's here to stay. And I think people will choose, and demographically, people have different preferences on what they want. But I think that as a real platform, it's been proven. I kind of wish we had done it years before, and I think everybody did after the pandemic. But it's something that's here to stay. And it's just really the tip of the iceberg. The ways that we can improve the kind of coaching and support and connection, virtual care is just the start of it. How we can interface with people, how we can collect data on how they're doing, and improve outcomes and engagement. We can also interact with our families in a hybridized way, if you can imagine that. So some of it will be in person, some of it will be virtual. You can give digital products for teachings and learnings. And so it's going to be a hybridized model that gets at people, and it really has the customer or the patient's focus. And I call it an ecosystem, where you're building an ecosystem around the person. So instead of this is what we do, come to us, it's we have these services to build around you. And we're uniquely positioned to do that because we have a research center, we have a graduate school, we have a publishing arm, we have a digital products line. And so because of that, we can integrate these business units together to really give everything that the patient needs and their family needs.
That's really interesting. And so that's really in sort of, getting into what my next question was going to be, was sort of aligning everything that Hazelden Betty Ford does around the patient to create more of an integrated ecosystem. And so putting together all the pieces that you have, but along also the innovations or prescription digital therapeutics or other technology-based solutions together to sort of to really build that around the patient and their family. Is that where you see things going?
Yeah, absolutely. To make it very, very concrete, let's say there's a person whose significant other or partner goes to treatment, and let's say they have children at home. So while that person's getting treatment in a hybridized way, digitally in person, we will offer parallel family services for the entire family. We have a children's program for their children. Our prevention programs may be in their schools. Our digital products will be able to help them with skill building. And our recovery capital services, everything from peer coaching to educating other people and reducing stigma, will help them interface with an environment that is more friendly and accepting and dignified as they interface with care. So our organization, partnering with others, can really touch people on multiple points, not just a treatment trajectory. And that's an incredibly bright future that we have ahead of us, and we're ready to seize it.
That's very cool. That's very cool. So shifting gears a little bit now, when you were announced as CEO, you said one of your top priorities would be advancing Hazelden Betty Ford's diversity, equity, inclusion efforts. And so can you tell us a little bit more about how you are prioritizing this and how you're broadening the banner of Hazel and Betty Ford to reach more people while also expanding opportunities for those who are employed at Hazel and Betty Ford?
Yeah, in our rich history, we've always spoken for marginalized people. We talked about the stigma of addiction long before it became a popular thing to talk about. However, we did so for a narrow demographic, and we're very humble about that. And what I recognize when I work with diverse communities is that they don't have the same stories of their grandmothers or their aunts or their uncles going to Hazel and Betty Ford, or going to a recovery community. And we have to create those bridges. We got to be incredibly humble on how we do that. And so we have to improve access to care. We have to build trust with these communities. We want to impact millions of people. And some of it is not just us treating the person. How can we help the clinics in those communities? How can we train those clinicians so that they have fidelity to a model and skill sets? How can we give them digital products and improve the services? So there's multiple pathways to help those people. But this also has to be reflected in our leadership. Our board diversity, our leadership diversity, these things are not lost on me. And I think that we have to think about equity in our hiring practices, have pipelines within. To give you a real simple example of that, things I'm planning on right now, we have a graduate school. So, everyone's talking about workforce turnover and we have our share, but we're really privileged in that we have this graduate school where we can train people to be counselors at our organization. We have this pipeline that's built in. And what we're going to do is we're going to enhance scholarships. We're going to look at loan forgiveness programs and paid internships and dually integrated counselor tracks where they can do both mental health and substance use disorders. So if you can imagine a person from a diverse community entering our graduate school, if they perform well, they're promised a job from the beginning, their loans are going to be forgiven, and they have the ability to get an enhanced license, that's a value proposition win. And so I'm less caught up in the semantics. I really want the practical opportunities and the pipelines, because that's how we're really going to accomplish goals with equity. And it's a deep commitment I have, and I'm very passionate about it.
Well, that's very cool. That's very cool. So I'd like to close our conversation today with a couple of questions about how addiction treatments and how it fits within the broader discussions around the ongoing transformation of care. And so, despite a growing public awareness and understanding of addiction as a disease and its impact beyond just the immediate individual, addiction and recovery services do not receive the same resources and attention as other types of care do. And you noted that at the beginning. It doesn't receive the same level of philanthropy or doctors to the field. And so what do you think is the root cause of this? And you've hit on this a couple of times, but I'd really like you to sort of expand on that a little bit more.
Stigma is more than someone being ashamed of their story. Stigma cuts across right to resources and talent and money. And so while we're being really creative with different ways to engage people, we also have to reckon with the fact that at some point, our patients, the people that we love and care for, also deserve the same level of care as people who have heart disease. They don't just deserve an app or virtual care. They deserve it all. And when you see a patient and a family member, they go to a hospital, a beautiful hospital, and they walk into the atrium and they ask where the mental health or substance use services are, chances are they get sent to the back annex. And the message sent to them from the beginning is very clear that they're a second-class citizen with a second-class disease state. And that's something we can't have. And so as a model of care, we want to mainstream addiction services. And so many of your other guests you're going to have on later, we want to partner with bright minds like that so that we can reduce stigma, improve resourcing, because at some point in this journey, we have to have that discussion because the people that we love and care for deserve better. They deserve more.
Yeah, very, very good, very good. And so sort of building on that, where do you see addiction treatment fitting within the context of the rest of healthcare? You mentioned it being on par. And how do we get there? How do we integrate it into overall care delivery moving forward?
Well, it's certainly not our efforts alone, but there's a lot of efforts to integrate it into primary care in other models, even outside the health system and peer support systems. And those kinds of integration experiments, I think, will be successful. And I think we'll hit upon ways to get ahead of people. At the height of the opioid epidemic, more people were dying from the opioid prescription than the side effects of any procedure that they were undergoing. But the emphasis was on the procedure and not on the side effects of the opioids. Through better integration, better screening, weaving in and feathering in not just skill sets, but talented people who can recognize addiction early, by making those kinds of investments throughout communities, we can reach that integration. We have some prime examples of how we do that. We have a patient care network where we partner with hospitals and large healthcare systems to improve their screening, improve their services, to build their services up in some ways. We partner with schools and other services that even before they get to the hospital setting, we can maybe do some early intervention work. And so there's lots of promising early results in integration that I think will build into something that is much more deserving, something that our patients really need.
Well, that's excellent. And, it's been great talking to you. You really have a clear vision for, how to build on the success of Hazel and Betty Ford over the time, and how to really engage with the healthcare system overall, and bring addiction treatment and recovery to the forefront as a typical piece of healthcare, not something that's different than all the rest of it. And so I'm really excited to see your work and see that grow. Is there anything else you'd like to add before we wrap up here?
No, I think you've covered it really well, and I'm really honored during National Recovery Month that you've given us this platform to reach more people, to start to normalize addiction treatment as standard medical service for people. And I hope that people can kind of feel the passion that we have in our organization for our mission. We really believe our mission is a mission of love. At the end of the day, all the science is cool and all the innovations are necessary, but we have a mission of love, and we're going to do more, and we're going to do better, and we're going to build bridges and have more partners. And so despite the pandemic, there's many exciting things. And so thanks for having us.
Excellent. And it was an honor speaking with you today. We're extremely fortunate to have you and Hazel and Betty Ford as part of the Medical Alley community. And we look forward to working with you to continue delivering hope and healing to patients and their families. So thank you again.
Thank you.
And with that, I will turn it over to my colleague, Frank Jaskulke, for the panel discussion. Frank?
Bobby, thank you so much. I really appreciate it. That was a wonderful conversation and a great message to finish on of an organization of love. I'm excited for the second part of the conversation, where we're to talk with a couple of other people working on the forefront of improving the treatment of substance use disorder. And Nirja Jordan and where did Yuri go? If you want to pop on camera, please do join us. We'll get started. As we're getting set up, I'll just say, as we're doing the panel discussion, use the Q&A function as you have questions. Send them in. I'll be moderating those, bringing them in the discussion. Also know we're still in the pandemic time. Some of us are working from home or non-traditional locations. If a cat pops up on the screen or a kid needs to cry, have some empathy, right? We're all dealing with this fun pandemic. And Nirja, if you're there, if you want to turn your camera on as well. And then let me just set up. So I've got the questions. I'm working on a small screen today, so I've got a little bit less. What we're going to talk about today is some of the innovative approaches that the public and the private sector are taking to better treat people who are dealing with substance use disorder and other behavioral health issues, but also to make public health better in Minnesota and around the world. And I'm so pleased to be joined by the three wonderful people that we have here today. And I'll start with just asking them to do quick intros. And Jordan, you're first up on my screen. So if you just give us a quick intro of you and your organization.
Sure. So glad to be here. My name is Jordan Hansen. I'm the CEO of YourPath, and we are the front door for healthcare for substance use disorders. I'm a person in long-term recovery, and I've gotten to see how our system is fractured and inaccessible and lots of times archaic. So I'm really excited about what we're doing and excited to be part of this conversation.
Thank you. And then Yuri, if you would.
Sure. Great to be here. Thanks for having me, Frank, and Medical Alley. So Yuri Maricic, I'm the Chief Medical Officer of Pear Therapeutics. I'm an internal medicine physician, and at Pear, we develop prescription digital therapeutics, which is software to treat disease. And we have 3 therapeutics that have gone through and received FDA approval or market authorization. The first is for patients with substance use disorder due to cocaine, cannabis, stimulants like meth and alcohol. The second is for opioid use disorder, and the third is for chronic insomnia. So looking forward to being here in the discussion.
Thank you. I really appreciate it. And then Nirja, if you would introduce yourself.
Thank you, Frank. Thank you, Frank. I'm Neerja Singh. I am the Clinical Behavioral Health Director for Department of Human Services, and I am over Medicaid behavioral health services. So really glad to be here. Thank you.
Thank you. I really appreciate it. And I might start with you to ask this question, but I'd open it up to Jordan and Yuri as well, which could you give us just a scope, a little bit of a scope of the challenges that we're facing in the community today and some of the issues we'll talk about, like how big of an issue is substance use?
I think as Dr. Lee pointed out, we are noticing state of Minnesota in opioid crisis. Our overdose death numbers are high, and part of it is accessibility to the treatment. COVID really taught us some lessons in terms of how vulnerable our system was in terms of behavioral health, and especially in the world of addiction treatment. I know telehealth did, and I'm sure we will be talking more about it as we proceed. But we are facing a lot of challenges in terms of access to the treatment. State of Minnesota, we are implementing 1115 demonstration waiver, which is a great way to build a continuum of care. We got approval from the feds, and it's reasonably going well at this point of time, but the time will tell. It's a demonstration for 5 years, so we will be gathering a lot of data in terms of access to the continuum of care options in the world of substance use. So we will be talking more about it, but at this time, access as well as the quality treatment. Especially when we are talking about our rural areas and our BIPOC communities, access is a big issue.
Indeed, and I think what you said there really important. Reasonably well, when we're talking about large, complex health issues, that's a good thing to hear, and I really appreciate the efforts that are going on. And to that access question, maybe I'll turn to Jordan first, you, and then Yuri. I want to talk about both sides of technology enabling or expanding access, but also some of the new challenges it might create. And Jordan, maybe you could start with talking a little bit about what you guys are up to and how it expands access, but where there's still gaps.
Yeah, our goal when we started Your Path, we started working on this maybe a year and a half ago. So great time to start a new business right in the midst of everything going on, was to expand access and to make use of our existing system. There are pieces of our system that are appropriate for some people, and they are also incredibly dangerous for others. And this is, I think, this is across the country, but the quality of care just is not consistent. And so especially when we're talking about opioid use disorder or treatment, there's still a block to using evidence-based medication. So we have medication that'll reduce overdose risk by 50 to 70%. It's not that we don't have the medications or the way to pay for it or any of that, it's the uptake of the system. And so really where our focus is how do we reduce the administrative burden on both the client and their family, as well as the service system, because really that's where I think we have lots of loss. This is where things get expensive, and this is where people are lost to care. So currently right now, about 65% of our patient population is of East African immigrant refugee descent. So lots of young men, Somali men, on our patient population. The access to care among our BIPOC populations, like Dr. Singh was talking about, these disparities are significant. They're universal, but very, very specifically, what we're trying to do is use the technology to try to make those gaps less dangerous.
Oh, well said. And I think highlighting those specific communities and developing unique approaches is such an important thing, right? It's not a one size fits all. And Yuri, what about from Pear's side? You guys are taking a kind of a unique approach to the treatment.
Sure. As you mentioned at the beginning, there's just a huge need depending on the stats. You look at, somewhere between 1 in 4 and 1 in 6 Americans in any given year will have a mental health diagnosis. And, just in 2020, we saw a 30% increase in opioid overdose deaths. And it took a previous 5 years to get a same increase of that magnitude. And yet, while that catches the headlines, we see stimulant use, particularly methamphetamines, alcohol use, and we have limited providers. We have limited treatment options. I think as Jordan was mentioned, we do have medications for OUD. We don't have medications for methamphetamines, for stimulants. And even in OUD, the majority of patients should be getting behavioral treatment alongside. And we've completely segregated care where patients get, and Dr. Lee talked about this, physical treatment or mental treatment. They don't just get treatment. They don't just get care. And stigma, I think, is slowly improving, but continuing to make challenges that roll into access. And so at PAIR and the work that we do, I think when we think about access, we think about it in several ways. One is, can you get access to a provider, but that has multiple dimensions. That's geographical access, that's temporal access, that's coverage, do you have insurance? And then are there good treatment options? And so this is an area that I think we all need to be working on. Some of the new innovations, particularly around expanded access, there's still significant challenges in socioeconomic status, underserved communities, particularly minorities. But I don't think that without people coming together, that it can't be overcome. One group that I'll just mention that we work closely with is a group called VinFen, where they go and they meet patients where they at. These are patients who can't even get themselves to a clinic or a hospital. And so they have like multidisciplinary teams and then digital treatment options that they can go and take people out for food. So they help address social determinants of health. And they continue to see them wherever they are in the community to ultimately get them care. And so this kind of, I think, flexibility and focus on understanding the different patient communities' needs is really important because it tries to get at treating the whole person.
There was a quick question from the audience. Yuri just asking, can you say the name of that program again?
Yeah, it's called VinFen. It was an outgrowth of partners in Massachusetts General Hospital in the Massachusetts area.
Thank you. Appreciate that. And then Nirja, both Jordan and Yuri and yourself mentioned this continuum of care, the access issues. Can you talk a little bit more about the work you're doing, the waiver you're working on, and some of the challenges in continuum of care, and maybe some of the things you're looking at today to build that continuum?
Yes. So Frank, when COVID hit, a group of like 19 states, their directors came together and Minnesota was part of them. It was a group called Medicaid Forward. And that group put out a report and it really kind of, the first thing that it identified a lot of things, and I can send the link to the report. But a couple of things which were very important was, first of all, like, remove barriers to access, especially for addiction treatment. And everybody talked about a lot of like stigma associated with seeking that care. So how will we integrate addiction care in our primary care models? So those are like, so when I go for my checkup with my doctor, what are some of the ways we can just kind of do that? I also get at least a screening for my addiction and mental health help right there. And then after that screening is done, then what are the ways we can build a system that, I have more motivation to go for treatment than to be worried about paperwork and eligibility requirements and like kind of, okay, one clinic to another. So this group really encouraged states, and Minnesota will be working on some of the recommendations that came out of this group. And so while working with this group, I also realized, like, we need to focus on prevention. We cannot always come after the fact and just kind of be in that reactive mode. So we really need to be focusing on prevention. And when prevention comes, Medicaid is like, well, you have to worry about medical necessity and all that. So for that, the states are looking at, especially Minnesota will be looking at our legislative proposals, looking at state funds to be bringing prevention-focused activities right in the community, right in our schools. So we were able to get some resources, financial resources, this legislative sessions to bring addiction-related prevention efforts in our school through our school-linked grants. So it's still in progress. We need CMS approval, but I'm really excited about that work. And as far as like 1115 is concerned, 1115 will help Minnesota get federal share for our clients who are currently in our facilities in IMDs. So that's the financial part of it. However, there is a huge benefit as far as quality of treatment is concerned, because every facility who is participating in 1115, they will get a raise. I think it's 15% raise, and then next year it's going to be more. So they will get a raise. However, they will have to maintain compliance with ASM standards. That would include addiction medicine, that would include medication assisted treatment, that would include a lot of like co-occurring stuff. So we are in the first phase of it. Facilities are really coming forward and registering. So we are really hopeful that the first report comes out of the outcomes of this demonstration. We are really hopeful that, and that will be public information. We will be sharing it with the community. So we are really hopeful that we will be able to identify, hey, we made progress here, but we still need a lot of work there. So mixing those two efforts together, I think would have like what we got from Medicaid Forward, adding prevention, bringing prevention to schools, like to our kids, and getting like solid outcome studies of our current model of substance use treatment in Minnesota.
And a follow-up that I think you partially answered, but we had a question from the audience asking, how is the state using the SUD block grant funding to advance access to care? And then Jordan, I want to come to you on a tech piece of it.
Well, state is, all that information again will come out. We are going to be investing part of that substance use block grant in creating and bringing models of care in Minnesota. One is like, I think Dr. Lee talked about recovery peers. So I'll just give one example, although like SUD block grant, we'll be sharing all that information. We are just waiting for the feds to approve our spending plan. But one of the aspects we will be spending is building recovery peers model for our women who are involved in child protection due to addiction related issues. So what this will do is we will be conducting a study, and this will all through, we'll send an RFP out, and if people are interested, please feel free to respond. But what we want to do is we want to kind of see if we can mix and connect the models of recovery peers and family peer specialists. And Minnesota was selected by the federal government to test it in the county where we have the highest number of out-of-home placement due to substance use issues. So that's like one example. But there will be like a lot of money we would want to really spend on prevention related activities. And I don't have a list here, but all that will be sent out once we get the federal approval for our spending plan. And also this year, legislation was like really closely working with us. They had a lot of interest in those dollars. So everything was not DHS.
Thank you. That helps a lot. And, Jordan, what I wanted to ask you kind of related to that, we heard a little bit about some of the payment changes, continuum of care. What's been the role of payment model innovation or lack of payment model innovation in expanding access or bringing new models of care out to individuals who need it?
That is such a large and loaded question in
In
some
30
ways,
seconds, go.
as we're in the midst of an opioid crisis and overdose crisis, and we're still fighting to get contracts. And without getting on too much of a rant here, I think it's imperative that we use both the carrot and the stick. I would love to see more forceful regulation and more assertive payment models from the state. In addition to some of the things that we've been talking about for a long time, and we're starting to kind of tiptoe into around value-based reimbursement. I think the ultimate piece is, and everyone's kind of hinted at this, Dr. Lee talked about it, Neera just mentioned it. The peer recovery specialists, I believe, are the answer to a lot of what ails us as a system. They immediately reduce stigma because they have some recovery. If we can get them aligned, and I think we can get some of those payment models set up, I think we will be better off for it.
Very good. And Yuri, I might ask you similar, but on maybe a national perspective as PAIR's rolling out, how do you guys see it?
Yes, I mean, I think value-based approaches are so important because they really align all the stakeholders. And we personally have been very eager to and have done multiple value-based agreements, including actually in the state of Minnesota with, for example, Preferred One. The challenge that we find, I think, with different payers is when you even when we have the data, because like we can see our patients using the therapeutic, what their outcomes are, both clinically and economically, is are payers able to, and do they have the infrastructure to work as well alongside? And oftentimes that's the challenge, is who has access to what data, and is there an infrastructure to do so? But I think it absolutely has to be the long-term answer, because it helps bring the providers and the payers and also the manufacturers and developers together all around the patient to make sure they're focused on getting the solution right.
You know, this is something we hear not just in this field, but in, I'd say, every part of healthcare, that the easy flow of data and information on what's happening or what we want to happen seems to be the crux of a lot of different challenges we have on the administrative and operational side of healthcare. And I want to build on that a little bit. You know, Nirja, towards the beginning, you had talked about not just continuum of care, but some of the administrative burdens. How do you think about that in the public sector, in the Medicaid realm, where in some ways you have maybe a little bit more of an end-to-end view of the individual receiving care?
So, Frank, that's an excellent question. And when you were talking, I started thinking about some of the studies that DHS will be conducting. And one of those studies really is pertinent to what the discussion we are having right now. And it got approved this legislative session on paperwork reduction for substance use disorder treatment. And which is like really interesting, because when we started, and one thing COVID did really kind of, that's the bright silver lining, is it like really forced us to break the silos. So like just all of a sudden agencies were working together, MDH, DHS, and even within DHS, we had like different parts of DHS who were associated with mental health and substance use treatment started working together, which was awesome. So what came out of those efforts were, we were not clear on what is Medicaid requirement versus what is the state requirement versus what is the best practice. So what we did was we reached out to our Office of Continuous Improvement, which is a phenomenal sub-part of DHS, and we have a flow chart now that internal to DHS. Now we at least know when somebody wants to start providing treatment in Minnesota and want to bill Medicaid for substance use disorder field, this is the first step they have to do. And this is the paperwork they have to fill. And then it goes on and on from there. We have to make kind of, if it's a state opioid response grant, we have to make these things. If it's not a state opioid response grant, then we have to do this. So we have now a flow chart. And we are working on, we are waiting for CMS approval for our spending plan, but we will be sending requests for proposal out to hire a contractor who can really help us analyzing that from the provider's perspective. We will be conducting focus groups. I think they will start sometime next month, bringing that flow chart to the providers across the state, whether they are Medicaid, whether they are Medicaid providers or not Medicaid providers. But we just want to kind of get providers' perspective on, do they have the same perception of what they have to do in terms of data reporting? And so that was like one little step in fixing processes. And I was really not expecting this much confusion internally. So I can imagine what's going to be happening when we bring it out. So based on those feedbacks, there will be a request for proposal going out to hire a contractor who's going to help us fix these processes. So I will share it as soon as it's out. And I would really encourage people to, if you don't want to apply, at least be part of the study. So that is one example of how we will be addressing the paperwork or whatever process issues, right from the day you want to be enrolled to the day you discharge a client and you want to get paid. Everything is going to be analyzed.
I really appreciate hearing that, because I suspect most of us on this webinar get this, but in healthcare, you have both, like, say, the end treatments and the things we do, And then there's the system we work in, and there is so much opportunity to lower that administrative burden and free up resources then that can be used for direct patient care for the things that have the direct impact. So I really appreciate you sharing that. I might shift topics just a little bit, and I'm going to pull in a question that came from the audience and tie it to one other we had prepped ahead of here, which was to ask about the term recovery capital. And Jordan, I might start with you on this one about, how does the current system that we have, especially in, like, say, post-treatment support, help promote recovery capital, and where might we be going with it? And I think Dr. Lee talked just a little bit about this during his remarks.
Yeah, I think we have some tremendous opportunities. I love the term recovery capital. There's different ways to measure it, but essentially it includes, social determinants of health, which I think is part of the missing sort of global context. So when we look at disparities in outcomes, when we look at, sort of our need to transition to an actual longitudinal chronic disease management, I'm not aware of another illness that we treat in the way that we treat substance use issues, being totally segmented from healthcare historically. So I think that there's huge opportunities. I know that the state is now reimbursing recovery community organizations and outpatient treatment providers to provide some of those supports. I don't think that those reimbursement rates are sufficient to actually grow and expand our recovery support network and structure. And I think what we've seen is historically treatment has been a place you go to and then you come back home. And really what we need to transition to is community-based supports that build on people's innate ability and their existing strengths to recover. And this is, I think, it's just the most exciting part of our work is being able to identify and connect with those resilient, existing community-based networks, because I think really that's what helps people get and then stay healthy.
Oh, very good. And just an observation, I've noticed in all the conversations I have around substance use disorder and treatment, it seems to be the area of healthcare where there is the most consensus that it has to be treated broadly and in more than just it's your doctor and patient or counselor and patient, like much more so than other areas of health. And Yuri, you talked earlier a little bit about social determinants of health with that program out of Mass General. Maybe you could expand on that a little bit, and how do you see from Paris' perspective the role of social determinants of health and the broader world that an individual exists in when dealing with this issue?
Sure. So to me, this really does get to viewing the patient holistically, and that is just a fundamental challenge of the way healthcare is delivered right now, is that everything's segmented. And there couldn't be probably a brighter line that you could find than between physical and medical. And Dr. Lee earlier gave an example of just where someone might go within even a healthcare facility who might not explicitly make that distinction, but just inevitably the way the system has grown up. And organizations that we work with, I mentioned VinFan, but I can mention those others all across the country are really focusing on integrative approaches. For example, we have some work we're doing with Kaiser where it's integrating behavioral health into primary care centers and bringing addiction care into primary care so that it's not addiction care, it's just care. And the need there is to then be able to focus on how do we engage patients writ large, how do we, in more complicated episodes of care with both physical medicine and behavioral mental health medicine, focus on clinician workflow, and how do we align then around what are the appropriate outcomes. So I think we have to measure our outcomes, we have to look at clinical outcomes, we have to look at economic outcomes and social outcomes, and then determine what are best ways to make improvements. And this is why this gets back to what we talked about earlier around value-based care, while it's so important, because if we have a single metric that we can start to align around in terms of value, and obviously there's different ways to measure it, but if we can align around that, then that allows some of that innovation around care models. And I really think, Dr. Lee also said this well around the future is synchronous and asynchronous. If we take a lot of the innovations around, say, virtual care and telemedicine, and all we do is a cut and paste of what was being done in a brick and mortar clinic into in front of a video screen, we'll probably have improved some access, but I don't think we're going to make huge headway on the value. We really have to take these innovations and redesign how we deliver care so that it is more holistic. It includes all the aspects of social determinants of health, and you bring the right care team around the right patient, and then you make sure that they get reimbursed in a way where the provider, the payer, and any other healthcare products are all being reimbursed according to the value that they're creating.
Right on. It seems to be a truism with any new technology. We first take whatever we had done before and just kind of stuff it into the new tech. But eventually we figure out new, different, better ways of using that technology. And I'm hopeful we're getting there. As we're coming up to the last couple of minutes, I want to end on a policy question, but maybe a larger, almost philosophical question. And Jordan, I'll start with you, which is drug policy in the US seems to be changing quite significantly, particularly around marijuana. Is that sort of like social, cultural policy change? Does it have a positive, negative, neutral impact on our ability to confront the serious issues of substance use? Jordan, what do you think?
I think it's a great question. I think our national discourse tends to be lacking nuance, and we just kind of flip-flop back and forth between prohibition and heavy-handed, sort of punitive models, and then other folks are, marijuana is going to cure your anxiety, your insomnia, cancer. It's going to help. I think that we have our work cut out for us. I think largely, though, it's been a really positive shift from our perspective, is that we have had, in my opinion, sort of a bifurcated system for a long time. You had the system that works for people with funds or commercial insurance, and you had the system for everyone else. And I think now that we're starting to have more conversations around equity, I think, at least we're talking about some of these things. Because while substance use disorders and mental health issues are sort of, to use the old cliche, an equal opportunity illness, the opportunities for recovery and recovery supports are not equally distributed. And so in some ways, I think this conversation is so overdue. Our largest treatment provider in this country are our county jails. And that continues to be a place around, we don't get any sort of Medicaid funding for treatment, and they're our largest treatment centers. So I think we have a lot of work left to do. If anyone wants to hear me rant for several hours after this call, just give me, send me a note, but I'll leave it at that.
I think that is a great spot to end it on, a very thoughtful point, a very provocative point, which is exactly what we want. I want to say thank you to everyone who participated today. Nirja, Yuri, Jordan, thank you for sharing your insights and your perspectives. And for those of you out in the Medical Alley community, thank you for working every day to make this the global epicenter of health innovation and care. If you have ideas for future content or you need help from the association, call us anytime. And I'll also say a last thanks to Diversified Plastics and a couple of gurus for helping to make this event series possible. Everyone have a great day.